score 3 or 4 or 5. When it is less than 5% involvement, upper lobe, if I see that it's less than 5%, I'll call it score 1. Okay. And basically, so less than 5, 25, 50, and 75. If it is less than 5, it is score 1. 5 to 25 is score 2. Then the next one up to 50%, 26 to 49 is score 3. Then we have score 4, and then we have score 5. So 5, 25, 50, and 75. Less than 5, 5 to 25, 26 to 50, 50 to 75, and more than 75. So this is how the scoring is done. We add up for each lobe. I'll show you a sample report as well. We add up the each score for each of the lobes, and then we give the scoring out of 25. Okay, then we give the scoring out of 25. If the score is less than 8, then a study called it as mild, and score more than 15 or more than 70. Various studies had various threshold. Then they called it a severe disease. Okay, so this is your 25-point scoring system calculated on 5 lobes and given a score. This is what we have already seen. CT score more than 80 is associated with increased mortality risk, and it was found to be predictive of death, and less than 7 was mild. Okay, less than 7 was mild. Now look at this patient. This is a CT film from a patient, and look at the images. So these are the images. We have taken the images. ये ऊपर trachea दिख रहा है center में. Then you can see the trachea has bifurcated into 2 bronchi, and that means we are going from above down. And you can see there's this liver also coming in. So we are going from above down. Now look at the upper lobes here. The upper part looks clear, and basically it's looking clear. And then as we go down, we start seeing some opacities. Okay, we start seeing some opacities. Now your CT films, ऐसा नहीं है कि इसमें सब images आ जाते हैं. It's always better for a radiologist to see the images on the console, that means on the screen, rather than just seeing the images or the films, because we don't take all the films, right? So many times, I've been receiving films ka images from many learners. So it's not possible to, judge or give a comment on just these limited images. We can better review them on the screen when we have all the images, right? So when you or anyone else, not only for COVID or otherwise as well, or any reason, make sure you get a soft copy as well, a CD from the respective center, so that you have it with you forever for review. If you want to get it reviewed from someone else, or during follow-up, if you want to compare, that is what helps us to compare. So CD is something that you should always be asking for. So this is the sample report that we have. So this is how we mentioned multifocal patchy areas of consolidation with ground glass and bilateral parenchyma with lower lobe predominance. And this is how we give the percentage of involvement. हर एक lobe का we mentioned कि right upper lobe इतना involvement है, right middle lobe, right lower lobe, left upper and left lower. We give the score 0 to 5, and then we take the total score. And we also look at the other structures. Remember, imaging, chest X-ray or chest CT is not only the lungs. We have to look around it, everything that is seen in the image, be it your airways, be it your vessels, the bones, the heart, and everything needs to be commented upon. Okay. So now this patient, since it was a known COVID status positive, COVID positive by RT-PCR, so even if you see that the score is 7, which goes into your mild, we call it CORAD 6 because it's a proven case. It's a proven case of COVID. So CORADs does not indicate your severity of the disease. Remember this. CORADs just indicates कि कितना suspicion hai of this patient having COVID. It's your CT score which tells you that, how much of the lung parenchyma is involved. So look at this other patient here, which of course looks much worse than the previous case that we saw. We do see some opacities here. We do see some ground glass here in this area as well, and on the left side as well. Also, let me clear this, the basic that in your CT or radiological films, your left is the patient's right and your right is the patient's left. So what you are actually seeing here is the right lung, and this is the right lung, and this is the left lung. Okay, that's your left lung. Look at how your opacities are more predominant in the lower lobes. How do I know the lower lobe? We can see the liver coming in here. So the opacities are more in the lower lobes predominant. Peripheral, they are more common. Subpleural area, peripheral, they are more common. And here the patient had a scoring of 15 on 25. So score basically indicates the extent of the lung involvement. Right. Now, what are we seeing here in this case? In this case, the finding that we are seeing here, this is your pleural effusion here. All right, this is your pleural effusion. So now you might have this query key. Why do you call this pleural effusion? Why this is not consolidation? Even this is looking white like consolidation. Now, pleural effusion, I had mentioned that your consolidation has air bronchogram sign. So I've discussed all of these in my sessions, when we have detailed sessions. When you have consolidation, you'll see the bronchi going through it. Pleural effusion, it is extraparenchymal. Bronchi do not go in the pleura. You will not see the air bronchogram sign. Plus, classically, you see this crescent shape of the level. You are seeing this crescent shape. It is occupying the entire hemithorax. The fluid is going in the dependent part. This is the posterior part. You can see the vertebra. Dependent because the CT scan is done in your supine position. So the posterior part becomes the dependent part, and that is where the fluid accumulates. So pleural effusion, not likely. It's a atypical finding or a rare finding in your COVID patient. If present, it has been found to be associated with mucormycosis agar hai, तो pleural effusion हो सकता है, but you should see other parenchymal changes as well. Right? And these are the areas of consolidation. Especially when you see that the pathology is unilateral, then it is less likely to be COVID. COVID is more likely bilateral. Unilateral one goes into your CORADS 4. It's not CORADS 5. Coming to some other fancy signs in your COVID CD chest that we are seeing now, we have the halo sign and we have the reverse halo sign. So I remember that is what the flyer read like. What's the halo or the reverse halo, and that is what we'll be decoding here. Now, I think I do have an image. Let me see if I have your image of halo versus your reverse halo sign. Right. So this is what is your halo and reverse halo. So in the halo sign, we have a nodule, that is a consolidation, very, very white, which is surrounded by this less white area. We can see the vessels in that. That is ground glass opacity. So halo matlab it is lighter. Halo is light, like you have the sun and you have the halo. Sun is more bright, surrounding part is less bright. So that is a halo. Reverse halo, when you take the lighter halo inside and you take the more bright thing outside, that becomes the reverse halo. So like you are seeing here, the relatively lighter area inside and the more brighter, more white area outside, that becomes the reversed halo. Until now, reverse halo was commonly seen in organizing pneumonia, which was previously called as cryptogenic organizing pneumonia. Now we are seeing this very, very frequently in the COVID era. Now, if we see reverse halo, we'll start thinking of COVID first rather than organizing pneumonia. So reverse halo is more commonly seen. Halo sign can also be seen. Okay, halo sign can also be seen. So we were discussing this image here. So this is where you are seeing the lighter area and the more white area surrounding it. That is your reverse halo sign, right? That is your reverse halo. The brighter part is seen outside. CORADS, this I've already told you. The initial CD patterns, the most common that was seen, ground glass, bilateral, posterior, multilobar, peripheral patterns, and consolidation was seen, but to a lesser extent. This we have already discussed. Typical findings, multifocal, ground glass. We have peripheral and basal distribution. There can be vascular thickening. This is a very, very specific sign of COVID. Angiopathy, vascular thickening, vascular enlargement, reverse halo sign, crazy paving, all of these are seen, right? Very atypical findings, which are not characteristic of COVID. Cavitation, tree in bud as we saw, pleural thickening, these are atypical findings, right? Now, let me just read out to you the CORADS 5, what all comes in CORADS 5, because we should know कि हाँ ये COVID है कि नहीं है. So this is your ground glass opacities, maybe with or without consolidation. In which regions? Close to the pleura, that is periphery. Pleura includes your fissures as well. And it is multifocal. and it is bilateral. So it should be bilateral, multifocal, subpleural. GGOs is the most common. That is the take home point. If one take home point from the session, this is the take home point, right? And then additionally, there should be at least one confirmatory pattern where you see the temporal evolution, like you see the crazy paving, you see the consolidation, and these are the findings. They can resemble organizing pneumonia also, like we said, the reverse halo sign. You might see the subpleural curvilinear bands as well. These are your CORADS 5 findings. Classical image here, ground glass, peripheral, ground glass. This is classical COVID findings that we are seeing in the peripheral subpleural location, classical image of a patient of COVID-19. This is the coronal image. Your CT scan can give the images in axial. The same image can be converted to coronal and sagittal. So we are seeing this peripheral subpleural opacities, bilateral, multifocal, COVID suspected CORADS 5. So this is classical. Time and again, I'm telling you, bilateral, multifocal, peripheral opacities is your COVID. Now, this is the progression. You see the ground glass, you see the crazy paving, the reticulate pattern, and you see the consolidation. Temporal evolution will be seen. Some other fancy signs, if at all you want to know. In the area of ground glass, we see this relatively black area. This is called as your vacuole sign. Vacuole, like an empty area there. That is the vacuole sign, again, which has been described. What are we seeing here? This is the vessel which is enlarged. A specific sign, vascular enlargement, like we saw the Dandelion sign or the feather sign. Okay. And this is your, again, the peripheral one. You might see this subpleural sparing, or you might see just this subpleural band like this. Halo, reverse halo. This is where we are seeing the halo sign, consolidation surrounding lighter area. This is where we are seeing the reverse halo sign. Lighter area surrounded by more white area. This is the reverse halo. So we might see halo sign. We might see the reverse halo sign. Both of them can be seen. Plus, there is something else which is called as target sign. So we have in the center, we have your white, then we have black, and then we have your white area. So you have the black area in between. So basically in the center, which we cannot see, is the vessel. So this again reinforces the fact that COVID-19 is more of an angiopathy, because all this is actually happening. You have the area of consolidation, then it's the normal black area, and then we have another layer there. So this is called as your target sign. Target, inner circle and an outer circle. So you have inner white and you have outer white, and in the center it is black. So you might see this target sign as well. Okay, so this is where we are seeing the target sign here as well. White area, another white area. Yahan pe normal hai. Target sign will be seen. This is where we are seeing your, again, ripple images, so that it gets area surrounded by the more white area. This is your reverse halo sign. Reverse halo sign, right? And we might also see some bronchial prominence like we are seeing here. It might indicate some traction bronchiectasis happening there in a patient, which generally we see in the later areas. We need to follow up to see whether it is resolving or not. Okay. So pleural thickening, some bands might be seen, but not very typical. This is very, very enlargement. The white one in the area of opacity, vascular enlargement, there might be bronchial prominence as well. Okay, bronchial prominence as well. So these are the findings that we see. This is your, how will you grade this patient as CORADS 1, 2, 3, 4, or because this is not normal. We are seeing the tree in bud pattern here, right? So you have this again, the branching nodules. We are seeing unilateral consolidation here, generally bilateral. So this comes under your CORADS 2, that is other in mycoplasma, something else. This is not COVID.